First off, I want to say a quick thank you to Dr. Arko Chandrasekhar, professor of medicine at Loyola University of Chicago, who many years ago agreed to allow me to reuse some of his x-ray slides. I've been a pulmonologist for decades, and his experience in the medical field has surpassed 60 years at this time. I feel like the title is pretty self-explanatory, but just to get us warmed up a bit, surely you noticed where it says look closely at the bottom that the lettering displays variable shades of light and dark. It has a line slightly off-centered, and certain letters are capitalized, others not, and not in the normal expected sequence. Oh, and the word closely is purposefully misspelled. It's okay if you missed all of that, but I wanted to implore you and kind of get you warmed up, if you will. I want to implore everyone on the call today that in order to properly evaluate a chest x-ray, you have to seek to be meticulous and detail-oriented. And we're going to practice this as we move forward. So don't worry, redemption draweth nigh. So as we move along, remember that not everything is always black and white, right? So these are just our general objectives for today. And I notice probably the most important for all of you on the call would be objective number 3, to practice identification of key items during chest x-ray interpretation. We're going to put it to use today. So things are quite different than they were even just 20 years ago or so. Long gone are the days of old where you would evaluate an actual chest x-ray film, waiting for it to be developed, throwing it on the old light box. We're in a different era now, of course. The benefit of x-rays being electronic are there's quick processing, almost immediate feedback, right? More rapid and easier access, and we now have the ability to manipulate and enhance the original picture, whereas before it was not so easily accomplished. We now can invert, we can change the density, we can use our mouse and scroll up or down to darken or lighten the image. We can even put it in particular views. Now, today's not about CT or MRI, but we know we have the lung window now that we can use, among other options. Okay, well, we've all been here, right? We go to the x-ray report and there's nothing there, but I want to show you, these are just a few of the more generic blurbs that I've seen over the years on more than one occasion that really doesn't add too much to the overall interpretation of the image. To that point, we are respiratory therapists, or maybe there's some other healthcare providers on the call today, but we must have some degree of expertise in order to appreciate what I like to call the need to know about our patient, as well as a sprinkling of the nice to know. I mean, what does this really add to our overall viewpoint? I would argue not very much, but realizing the baseline in which to compare it is probably more important in the scheme of things than just a simple comment that you see here. Okay, so what are we looking at here? In particular, I can get my slide to change. There we go. Not everything is black and white, as I mentioned. Well, I guess technically on chest x-ray, it really is kind of black and white, but what's wrong with this picture? What's wrong with this patient, I would ask? Well, there's nothing wrong. This is most likely, even though it's not a full inspiratory film, this would be considered as near a normal chest x-ray as you're probably going to come across. This is an anterior posterior chest x-ray, meaning it was shot from front to back. Most patients that are quite ill, that are in the acute care environment, that are non-ambulatory, they will typically have an x-ray shot while they're still lying on their back. The film is put underneath them and the x-ray beam goes from front to back, and thus the name AP, standing for anterior posterior. Now here's a great reference of some of the most common landmarks which all clinicians should note when glancing over a chest x-ray. Now I realize many times, particularly respiratory therapists, we have but only a moment to quickly evaluate our stuff, right? I mean, I'm there, ET tube, we're looking at lung fields, and then we must move on to something else. But I would argue that it doesn't take more than a moment or two to scan over a chest x-ray. Particularly with a little practice and experience, you can pick up on quite a lot, but a systematic approach is best. And there are nuances to everything, and certainly there are exceptions to the rule, But what you're seeing here on the screen are landmarks that most of the time, less maybe the breast shadow because we have different patients, of course, but most everything you see here, you should, under normal circumstances, be able to identify with ease if you know your anatomical landmarks. And I want to remind all of us that there are certain landmarks that are relatively immobile outside of a traumatic event. Any type of bony apparatus, any type of soft tissue, such as the heart, yes, there's some variations, but most of the time we know that the clavicles, the heads thereof of the clavicles should not typically move in a dramatic fashion. We know that the spinous processes of the vertebral bodies should not be out of alignment. Now, there are, of course, pathology to everything, but just forming a perspective to start. This is just another iteration of a supposed normal chest X-ray with some of the more pertinent structures labeled. Now, there are variations to some of the terminology. The aortic arch is oftentimes called the aortic knob region. You've got what is labeled here as the pulmonary trunk, and sometimes that will be considered the general region of what is known as the AP window, aorticopulmonic window. You have the fissures that are labeled in the diaphragm, and then it's sort of cut off here, but that says costophrenic sulcus. Sometimes that is affectionately known on either side as just an angle. And you've got several other things as we'll get to moving forward. So a good systematic approach is extremely important when interpreting any diagnostic test, really. For chest X-ray, what is shown here is going to be a relatively easy way to remember, and it goes in alphabetical order according to proper sequence of evaluation as well. For instance, we call this the ABCs of X-ray. And you can see from the publication here, this has been around quite a long time, and it's been reproduced in various iterations, but it still holds true that if you want to be a systematic chest X-ray reviewing expert, if you will, the ABCs are going to be a really good pattern for you to adopt. We start with airway and adenopathy. In other words, we look, is the airway midline? Is it patent? Do we have an artificial airway? Is it a tracheostomy? Is it an endotracheal tube, such as an oral endotracheal tube? Do they have normal airway dilation? Is it tortuous? Do we have some stenosis? Do we have any other apparatus, tracheal stent, etc.? So always start with airway, and I don't have to tell a group full of RTs that. Adenopathy would be lymph nodes. Do they have lymphadenopathy? In other words, look at the hilar region. That's prominently where most lymph nodes are noted on a chest X-ray. And then we go to B, A, B, C. I can do the alphabet on some days of the week. Sometimes I have to think about it, but B for bones. So most of the bony structures are not mobile structures. They have some degree of movement associated with them in the small joints, but unless I'm talking about a traumatic event, blunt force trauma to the chest, motor vehicle crash, you've seen all of the scenarios, you that work in trauma. Yes, the ribs are one of the first things you probably will note that have a abnormality when speaking of bones, but of course the position of the patient in the bed and their clavicles can have a clinical implication. And then we go to the ABC portion, which is the cardiac silhouette. So I have a question here on the screen, and you can answer it amongst yourselves there, but what is a normal cardiothoracic ratio? In other words, what is a normal transthoracic diameter to transcardiac diameter? What's the proportion that the heart should occupy in the chest cavity when we're talking about looking at just a single image from a frontal plane? Well, it should not occupy much more than half, and most radiologists would agree anywhere from 55 to 60% is that gray area, pun intended, where we consider maybe we're on the verge of cardiomegaly, but not quite there. Now, there's another thing to keep in mind, whether the film was taken at full inspiration or more close to expiration, and we don't always have that luxury of being present when the film is shot. Now, I know in the neonatal intensive care, sure, you're there, you're helping position the patient, but in the adult population, one of the first things they do is make sure you've exited the room and you hear that famous shooting x-rays, and there they go hitting the button. The D in the ABCDs, diaphragm, we're looking at not only is it smooth, rounded, domed, is the right slightly elevated above the left, which is to be expected with the liver, the anatomical position of the liver, but do we have the costophrenic sulcus, or the angle as it's also known? Is it patent? Is it sharp? Everything else, I know you thought we were going to go to Z, luckily we're not. We'll end with E here. Everything else is basically outside of what we did not list here. So just a good systematic approach, and I'm going to use this as we move forward in interpreting the various chest X-ray examples that I'm going to give you. All right, a good systematic approach, any diagnostic test, but you have to know the anatomy in particular to evaluate a chest X-ray. When evaluating for diagnostic purposes, a picture of the human body would not it stand to reason that a chest X-ray would encompass just about everything you see here, less the pelvic region. Particularly one such as a chest X-ray where the image is simple, black and white with a little gray, and is only two-dimensional, it is necessary that you are able to reference normal anatomy in order to identify any abnormality. You have to know the anatomy. Yes, anatomical landmarks are important, but also each major soft tissue structure, such as organs and their normal arrangement, must be front of mind. That way, as you scan over a 2D X-ray, you're seeing in your mind's eye the underlying soft tissue structures, and that is what allows us to form a clinical assessment from a single image, right? Again, what is shown here just for perspective, we're building up here, is most likely what is known as an AP chest X-ray, an anterior posterior. And before we go much farther, let's do a quick overview of X-rays in general and just brush over some key terminology and concepts. Some dealing with quality and others just defining the various descriptors. So when you talk about an AP X-ray, we're saying it's shot from anterior to posterior, from front to back. Most of your patients that are bed-bound, non-ambulatory, have a film slid under their back, or they might be prone, and then it's a different situation, but we're shooting the X-ray from front to back, that's AP. Whatever is closest to the film itself is going to be more resolute, more clearly delineated. Whatever is farthest away from the film itself is going to be more magnified and larger, but you lose some degree of clarity. Although this is not as much an issue modern day because most chest X-rays are shot using either digital or computed radiography, it's still worth noting that overexposure causes the image to be dark. The way I remember this, I use a mnemonic device to remember this. If you get an overexposure outside to the sun, most of us burn a little bit, but you're going to become darker. Your melanin gets stimulated to produce more en masse. A good way to remember it. So under these circumstances, the thoracic spine, mediastinal structures, the retrocardiac areas, and nasogastric and endotracheal tubes are well seen under most circumstances, but small nodules and the fine structures in the lung cannot be seen. If the image was obtained by using either digital or computed radiography, which is mostly the case, we know the image can be windowed lower on the computer, resulting in a more interpretable image. So underexposure causes the image to be quite white. There is a major problem for adequate interpretation here. It will make the small pulmonary vessels appear prominent and may lead to thinking that there are generalized infiltrates when none are really present. Underexposure also makes it impossible to see the detail of the mediastinal, the retrocardiac, and even the spinal anatomy. So with digital or computed radiography, nothing can be done to an underexposed image necessarily to improve the image. Now, you can change the way it's viewed on the computer, but once the image is shot, you're still limited on the adjustment that can be made. It's sort of like if you take a bad picture, you can only Photoshop, you can only brighten it so much until it begins to lose clarity. And I know none of us on the call have edited our pictures before we post them to social media. Surely no one on the group has done that. All in all, just assure that you're adjusting your chest X-ray contrast accordingly. Don't overdo it. So when you're viewing it, it's to assure you don't miss anything important or pertinent, but you want to be sure if you have that ability to adjust the density, and most of us will on our computer-generated images, do it with some caution and make sure you look at both sides of the equation. So just some terminology that we tend not to think about maybe all that often, particularly if you've been in clinical practice a while, but it's worth mentioning. Be reminded that structures closest to the actual film will have highest resolution on the image, whereas structures farthest away from the film will be enlarged or magnified. So on this next slide, I have a few examples. And before we move on, though, the AP part I've talked about, the posterior anterior PA X-ray, we're shooting the X-ray from back to front. This would be more of your patient that goes in for a chest X-ray in a clinic in an outpatient setting where they're asked to sort of hug the film and the X-ray beam is shot from their back to their front. Important to note is the term PA or AP X-ray describes the direction of the X-ray beam. PA, posterior anterior, means the X-ray was shot from back to front, whereas AP, chest X-rays, the X-ray is shot from front to back. Here we have a chest X-ray of the same patient. On the left, where the cardiac silhouette is a bit more defined here. If you notice, it's discrete, but I want you to center in on what I'm trying to really get across here. You see, it is a much clearer picture if you look at it in great detail than over here. And you say, well, these were shot hours apart. It's not true. I'm telling you, shot on the same patient within the same few minutes. You'll also notice something that is in picture B, this straight line on each side that does not show up in picture A. Same patient, same time frame. I mean, look at the diaphragm, almost identical. What you have here are the scapular borders for the B version. The B version, as I mentioned, would be more of your anterior posterior. So whatever was closest to the film is more resolute. That's an easy way to tell most of the time. I would say 90% of the time. If you see clearly delineated scapular shadows, and this is what we see all the time in the ICU or the acute care environment where they're non-ambulatory, it is an AP film. So remember, what is closest to the film is most resolute or sharp, and what is further away from the film is slightly enlarged and magnified. Many times the layperson, of course, would do this, but certainly not the RT, but even the average clinician might overanalyze an X-ray and say they've got slight cardiomegaly. But you have to remember what's farthest away from the film gets slightly magnified. So you can see the size of the heart here for A. This would be a posterior anterior film. Image is shown as closest to the film would be the heart, and here it's a little farther away, so it becomes slightly enlarged. Let yourself kind of sit back a moment and take that in. So on the left, we know it's PA. On the right, even if I only remembered the rule here where I see perfect scapular shadows, most likely would be an AP X-ray. Just a general way of thinking about it. Most of what we would likely encounter in acute care would be an AP chest X-ray when patients are lying facing up. Supine in the gurney, and the rad tech comes into the room and slides the film under the patient. And we've all helped with that process if you worked in an ICU, right? In a standard outpatient or clinic environment where patients tend to be ambulatory and very mobile, at least some, they can be maybe more easily or creatively positioned as shown for the standing avatar here in the picture. Recall that certain landmarks, unless there is an inherent thoracic abnormality or some sort of trauma, they're fixed. The bony landmarks should not move, and they should lend a good reference point when evaluating a standard chest X-ray. You must be familiar with the underlying anatomy and soft tissue structure orientation to appreciate not only what should be there under normal circumstances, but also you should just be able to recognize what should not be there in case an abnormality is present. And it's a lot to ask to rule out and to rule in certain things when you have only moments to glance at a chest X-ray, but hopefully we're going to practice that today. Here's an example. Well, let me ask you first, what's your first thought? Is this a PA X-ray or an AP X-ray? I'll give you a little moment here to look. I don't see scapular shadows. However, you've got a patient who is adjusted in the bed. You don't always see the scapular border. If you know they're in an ICU, they're non-ambulatory, 90+% of the time, it's going to be an AP chest X-ray. And I say this often, but you must be familiar and able to recognize normal in order to properly appreciate an abnormality. Reference is everything. With chest X-ray as well, similar to with any diagnostic, it is of course helpful if you have perspective of the patient's baseline or at least a prior chest X-ray, something to compare it to, but oftentimes you just don't have that luxury, particularly in the emergency department or when the patient is in the clinic getting formally diagnosed for the first time. At that point, you must fall back on your appreciation of normal and what it should look like. And it does take practice. We've all seen these schematics many times, I'm sure, but be reminded that yes, we have two lungs, each with lobes, but many segments. It's just a good reference as you consider what specific portions of lung tissue might be affected by disease and how that might affect a patient's chest x-ray. And we're going to get into some good practice here in a few moments, but still making sure we're together, laying some groundwork. And don't worry, we're going to jump in for you super clinicians out there and give you some challenges here coming up. The bottom left here represents the lung's extensive major vasculature, and the upper right pictured is what we affectionately call the tracheobronchial tree. All the repeatedly bifurcating airways that create issues for those in pulmonary medicine, the good TB tree, right? We're just building better perspective here today. Do recall that the vasculature traces the bronchial tree. It's almost a 1-to-1 ratio. Now, there are certain vessels that are feeding the structure itself and providing nourishment to the actual tissue. And then other blood flow, of course, is supplying the alveolar capillary interface where gas exchange is actually occurring. But nevertheless, bottom left, you're looking at vascular markings. Upper right, you're looking at airways. They look very similar. It's because they trace the same path. And that's just a free clinical nugget, even though it's just a chest x-ray talk today. Here's a patient that has a pulmonary arterial catheter inserted with contrast dye, being administered probably to make the prominent arteries more prominent. And you've got tapering great vessels of the hilum, which you can easily see. So the tendency is to mostly focus on the lung fields when interpreting a chest x-ray. But certainly there are many clinical implications of prominent vasculature. When you see blood vessels that are easily seen, even prominent, if you will, and they sort of are much different than what you would see in a typical patient, that usually means that they have some type, it could be fluid accumulation, it could be pulmonary hypertension, something is there causing there to be a darkened density. And just before we move forward too much, radio-opaque is white, radiolucent is black. So anything that becomes dark is going to be something besides air. And on this next slide, I hope you'll remember this the rest of your professional life here. The densities on X-ray, they follow a good mnemonic device. This is what we teach our students, acid-fast tuberculosis. Now, I know we're not out there staining all the time, but it's just a good way to remember AFTB. This is the thing you need to remember: air, fluid, fat, tissue, bone, and then calcium is in a league of its own. I mean, chest X-ray interpretation can be extremely vague at times, given the limited color scheme. I mean, we're literally dealing with various shades of black or white. And yes, there's some gray, but it's all black and white, little gray mixed in. Well, density does have meaning and relevance. Case in point, let's explore a bit here. On X-ray, there are two main densities. There's radiolucent, which is black, and there's radio-opaque, which is white. So you have air, fat, tissue, bone. And if I read it again, air, fluid, fat, tissue, bone, and then calcium is in a league of its own. This is in order of increasing density. So starting with air, we would call this lucent. This would be radio-opaque. Tissue would be more radio-opaque than fat and fluid. Bone would be the most radio-opaque of the AFTB sequence. Calcium happens to be the most dense. We call this metallic density at bedside. You get somebody with a gunshot wound that has bullet fragments, it's going to be calcium density. It's going to be darker or more radio-opaque than certainly air, darker than fluid fat, darker than tissue, darker than bone. We can have calcifications of tissue and calcifications of bone, but it will be more radio-opaque. So you should be able to pick up on that the more that you practice. A little brain break. Here's a prominent ad for cigarettes from yesteryear. I mean, it can't be that bad, right? More doctors are smoking Camels than any other cigarette. Of course, later we come to find out one of the few filterless, most cancer-causing versions of the cigarette was the Camel, the original unfiltered cigarette. Kind of sad, right? All right, let's get warmed up a bit to do some practice. So take a moment. What type of chest X-ray are we viewing here? Is it a PA, posterior anterior, Or is it an AP, anterior posterior? Now, probably it's a PA X-ray. There's no scapular shadows. There's no perfect scapular shadow border line here, as we'll see coming up in some other X-rays. And likely this would be considered normal. Now, some of you on the call say, well, I see some fluid overloading beginning to start, maybe some infiltrates, but recall that when you have a flattening of the diaphragm on the non-liver side, and this patient has no history of COPD, hyperinflation, or air trapping, most likely this is nearer to a mid-inspiratory film, not quite full expiratory or full inspiratory. We've got doming of this side and kind of flattening of this side. So it's difficult to say unless you're there when the X-ray is shot. We're talking about, seconds of time, but probably this is a PA X-ray. Also notice that the heart itself clearly delineated, but seems fairly small. We don't see too much, and I say this tongue-in-cheek, microcardia, so it's all pointing to being a PA film. When in doubt, read it out. Look in the EHR. It should denote it somewhere, maybe even on the film itself. Here we have a lateral, and we are viewing the right side of the patient. And I did not mention before, but I will now, that, by the way, a chest X-ray is always described from the patient's point of view. For instance, if you're referring to the right or left on a chest X-ray, it's from the patient's right or left, not ours. So in this case, we're looking at a lateral film. This is, of course, the spine. This is the front of the body, the anterior portion of the body. This will be looking at the patient's right side. You can see, we'll label some of this moving forward, but you can see the two stripes here. The right hemidiaphragm typically is more elevated than the left because of the anatomical positioning of the liver, and that's a normal finding. Just a few key structures labeled for reference. Now, these are bony, hard structures that should be reliable landmarks unless there's just some genetic abnormality or trauma present or just something really unusual. These are relatively immobile structures. You've got the scapula, the clavicle, the ribs, and the vertebrae. Most rib breaks, just a little clinical nugget, take place just anterior to the angle. This is where most of the stress and strain take place when you've got crush injury of the chest. You don't see a lot of rib breaks here. You see some displacements on occasion. But this is a relatively normal chest X-ray. In the frontal view, also known as the anterior plane, only 10 ribs are technically present. Ribs number 11 and 12 are floating ribs, and they really do not enter the frontal portion of the body, right? I mean, remember, anatomy, anatomy, anatomy. The average radiologist probably knows as much of the anatomy as would an anatomist. They have to in order to identify all potential abnormalities, right? And we need to be anatomy experts, at least for the chest wall, because we're looking at chest X-rays, hopefully on the daily or whenever you are working, depending on your area. I know some of you may be doing PFTs or out in the outpatient environment, don't see them as much, and that's okay. So a good clinical nugget here. Note that the thoracic spine begins, of course, with vertebrae number 1, T1, but T1 also happens to have the widest transverse process of all the vertebral bodies in the thoracic spine. So what I'm trying to say, this is a great landmark to indicate where the thorax actually begins. It happens to be the widest transverse processes of the thoracic spine at T1. Very easy to find, and we're going to practice that coming up. Just a good reference slide. You want to see that the clavicles are centered, they're on the same level, called clavicular symmetry. With clavicular symmetry, it can be skewed if the patient's malpositioned in the bed. I mean, if somebody just does a shoulder shrug while the X-ray is being taken, you can have clavicular displacement to a degree, but the heads of the clavicle near the actual manubrium should not shift unless there's trauma, dislocations, something of that nature. Now, here's another good way to look at it. You can find your clavicular heads, which are shown here on the arrow points, and you can find your trachea, which we can easily see. It's radiolucent here. The reason it's labeled not centered is the center point for all chest X-rays should be the spinous process of the vertebral body. And that line is kind of covering it here, but here is a spinous process. And to the point I just made, this widest transverse process that I can easily delineate, that's going to be T1. I know that's where the thorax begins. And you say, of course, we're in the chest cavity, but it helps to find these landmarks on your patients. And of course, this is our center point. This is our reference point for perfect centering of the airway with the spinous processes. And notice the airway is slightly offset towards the patient's right. So we would say there is a very mild tracheal deviation towards the right in this case. Here's that transcardiac to transthoracic ratio. And it's how we subjectively determine whether there is maybe the presence of cardiomegaly. Basically, we're comparing the width of the heart to the width of the anterior thorax. And if the heart occupies much more than about half of the thorax, cardiomegaly may be present. Do recall that for an anterior posterior, an AP chest x-ray, where the heart is further away from the actual film, cardiomegaly may be incorrectly assessed because the heart is naturally magnified a bit more on an AP chest x-ray. And what these newer software options allow you to do is to measure exactly what is the transcardiac to transthoracic diameter. But if you're not well versed in the software, it's no problem. What you can do is you can glance, and in your mind's eye, the rule of thumb is, does the right anterior cardiac border, if it hit the edge of this spine here on the right side, does it occupy the entire heart, the rest of the hemithorax? That is a guarantee for cardiomegaly. From that point on, you get 10 radiologists in a room. I'll still say just 9 because there's always that one, right? But 9 out of 10 would agree. That would be cardiomegaly if your heart occupies one side of your hemithorax and begins to overlap the spine. Just a good rule of thumb. This is a good reference picture. Note that there's really no left atrium viewable in a frontal plane, and most of the left ventricle is in the posterior plane. We know that the left ventricle, as far as sheer volume, is just as large as the right. In fact, in its thickness of the muscular layer, it's 3 times as thick, but you don't see it as much because the heart is rotated downward and to the left. Remember, an X-ray is just a 2D image. It's not a CT scan or an MRI, right? More good landmarks to note, all of which in this example are soft tissue and can be hidden by other soft tissue structures. We call that silhouetting. Silhouetting is when two structures of similar density contact one another and the borders of each are lost or obscured. These are just good landmarks. I would say of the 3 labeled here, the one you're going to see most often will be the aortic knob. And something you can look for, and we're going to see this coming up in a few examples, look for a ring of calcification in the aortic knob. And if you see a ring of calcification, you know that there is significant cardiovascular disease. We know if it affects the large vessels, it's certainly affecting the smaller ones. That's where it actually starts. And I'll bring you back to that here in just a few moments. Just some different width patterns, a few more good landmarks for reference. Notice, as expected and considered normal, the right hemidiaphragm is slightly elevated above the left. And that's because of that natural anatomical situation of the liver. Just some other things to think about. You've got your paratracheal vessels in the general region is labeled. We all know where the heart is. The heart can become somewhat compressed very easily. What you're looking at here, I'll give you a little bit of insight what's to come. You've got somebody that has hyperlucency. You see how it's more black in the mid-lung than it is anywhere else in the lung fields? Now, some could argue you've got breast tissue overlap, but there's several things to note here. You've got an increase in rib spacing. You have hyperlucency in the mid-lung. I know this patient has some degree of hyperinflation. Is it air trapping? Well, clinical history would tell that story. Are they at full inspiration or full expiration? That would tell the story, but I know I can easily say with confidence they've got some increased lucency of the mid-lung, increased rib spacing. There's definitely some hyperinflation in the mid-lung. What you're seeing here is a little bit of darkening of this particular area. You've got breast tissue overlapping the diaphragm. They're both kind of similar density as far as the tissue is concerned, and it darkens where the overlap is located. And you're seeing an example of that. It's not a perfect silhouette because you can still see the borders of each. The only time you lose the borders of 2 overlapping structures are when they're in very close proximity to one another, almost touching, if you will, and you have the densities that are equal. And we're going to look at that coming up a little more. Here, we're just zoomed in to approximately the level of the carina. And most of you probably are very well aware of where the carina is located when you're doing your procedures, but most adults on chest x-ray, the carina is located at about T4 to T5 posterior vertebral body. In other words, if you can find that widest transverse process, and I'm going to demonstrate it on the slide to come, if you can find the widest transverse process, that thoracic number 1, and you can count down your vertebral bodies down to 4 or 5, almost 100% of the time, you're going to find in the adult, that is where the carina is located. Now notice in this slightly zoomed in image, the clavicular heads. And of course, all the structures denoted are labeled, but just recalibrating our perspective before we begin to practice chest x-ray interpretation, you need to know where these are located. So looking at it here, case in point, you've got the clavicular heads, which look aligned in the same plane. We have the trachea, which is slightly offset, just ever so slightly towards the patient's right. These are my spinous processes. I can see what are sometimes affectionately called the wings. This is the widest transverse process of the thoracic spine, T1. And so that would be my spinous process of T1. So 1, 2, 3, 4, we get down to 5, and here we are. There's the carina in the adult. Now, there can be some variation to this. If the X-ray beam is shot superiorly, it makes everything look like it's further down. That would be ET tube, that would be suction catheter, any catheters. When the X-ray beam is shot from more of an inferior view, it makes everything look a little bit higher or more shallow. Now, this really comes into play in the neonatal infant pediatric population. You need to make sure, and rad techs are highly trained, they know what they're doing. You need to make sure that that X-ray beam is shot as perfectly centered as possible. And that's why that you'll see those crosshairs show up on the patient's chest wall just before they say shooting X-rays. They're trying to ensure it's as centered as possible and not being shot superior or inferior. Here, the aortico or aortic pulmonic or aortic pulmonary, as it's called, window is shown, also known as the AP window. As well, you have the infamous aortic knob, and the left hilum is highlighted. Recall that the aorta is just like any other malleable tube under pressure, in that a patient with hypertension, particularly if it's uncontrolled or under-controlled hypertension, they're going to possibly present with slightly uncoiled aorta, causing the aortic knob to be quite prominent. Another consideration is that calcification I mentioned earlier. Calcium is the darkest density. It's going to be easily visualized at the aortic knob, almost like a perfect ring, and we'll see an example of this forthcoming. Here's just an example of a few more pertinent items of interest. An osteophyte, by the way, is just kind of like a bone spur or a bony outgrowth, very common in arthritis patients, usually from just generalized degeneration of cartilage. So a good example here of the various levels of each hemidiaphragm under normal conditions. Do note that the costophrenic angle, also known as the sulcus, appears to be rounded and almost blunted, but this could be an optical illusion. You see where they're labeling that costophrenic angle. It could be an optical illusion if an anterior rib is crossing over at just the right spot. Otherwise, recall that a blunted costophrenic sulcus can indicate a pleural effusion is present, and that's very important to note. A relatively normal chest x-ray here, and in particular, note the labeled air bubble, indicative of typical stomach gas, not necessarily a significant finding. This does not mean it's air trapped in the lung tissue. It is air in the stomach itself, also known as flatulence in the making, or maybe a belch. This transverse fissure labeled here is rather discrete, which is why it's called out. If you're able to see a fissure with ease and the image is not zoomed in like it is here, likely there is either a small amount of fluid in that fissure, allowing it to be visualized, or there is some degree of scar tissue or inflammation present. That's the only time really you'll see a fissure. Now, the other caveat, I guess the exception to the rule, is if you see the fissure, you probably are dealing with a patient who's relatively thin, lower muscle tissue, a well-penetrated, well-shot x-ray. You might be able to pick up on that fissure, but most likely you're not. Otherwise, a minuscule potential space such as a fissure should not easily be seen or visible on a typical chest x-ray. Here is labeled the thoracic diameter. You would then compare this amount, this measurement, to the width of the heart. known as that transcardiac diameter. Recall that transcardiac diameter shouldn't be much more than about half of transthoracic diameter under normal circumstances. Of course, you'll need to consider whether the patient was at full inspiration when the image was shot. Also worth noting, a patient with hyperinflation will often present with a lower transcardiac to transthoracic ratio compared to a patient that has cardiomegaly, where their transcardiac to transthoracic ratio well exceeds the 50%. Here's a great lateral view looking towards the patient's right side here. Note the labeled anatomical landmarks, and this is an overall simple yet valuable reference just to create perspective. And what's not labeled but exists here, no doubt, is the retrosternal airspace just behind the angle of Louis, that manubrial sternal joint. This is the same view, still lateral, same patient, looking at the patient's right side. Just a few additional structures are shown. And my understanding is this slide set will be made available to you. So it's just a great reference to have on your electronic device, on your phone as you operate at bedside. It's just a great reference to look back on. Here, once again, the aorticopulmonic window is labeled, as well as that retrosternal airspace, which incidentally, the retrosternal airspace becomes quite prominent and enlarged and hyperlucent in patients with air trapping or hyperinflation. Air trapping doesn't guarantee the presence of hyperinflation, although with hyperinflation, there is always air trapping present, right? I know, makes you think. So this is just another view. The right hemidiaphragm is normally slightly elevated above the left due to the anatomical situation of the liver. Of course, it's not always the case when certain disease is present. And one thing to note that we see more often than not is if you've got a patient with cirrhosis, the hemidiaphragm, particularly the right-sided hemidiaphragm, may be significantly elevated beyond the left side. I know we kind of have this thought every once in a while when you pull up an x-ray and you didn't expect what you get. So with the right upper lobe, I know it's a very simple picture here, probably self-explanatory, but I want you to be able to appreciate, because we get kind of in this rut of looking at just an anterior plane, an anterior view each time, and we forget that there is a certain depth of occupation of a particular surface area of a lobe of the lung, such as the right upper lobe. Well, notice the right upper lobe in a lateral view. And be reminded that a majority of the posterior surface area of all the lung tissue is attributed to the right lower lobe, as you'll see here in a moment. So I want to back up just for a second here, looking at right upper lobe on an anterior view, and then a lateral, just how little of the lung tissue in the posterior plane that the right upper lobe occupies. Here's that right middle lobe. I'm going to jump ahead and jump back again. Here it is in an lateral view, and you can see the right middle occupies almost no surface area in the posterior lung tissue. I love this picture because this is one that you can pick up on just about every time. If a patient has infiltrates in the right middle lobe, you're going to completely lose the right anterior cardiac border. This is where we often see silhouetting. So once again, right upper, we get to the right middle because it butts up against the right anterior cardiac border. If you have a pneumonia, you have atelectasis, any consolidation or infiltrate for any reason in this particular area, most likely you're going to lose the clear delineation of that right anterior cardiac border. And here is just a lateral view. You can see that right middle lobe sort of aligns directly with where the heart would be situated anatomically. Now we're on the right side versus the heart on the left, but you get the idea. So this is the right lower lobe, and what I'm showing you here mostly is occupied posteriorly. You'll be able to see it in a lateral view just how much surface area, here we are, that the right lower lobe occupies. So going back here, you have to be able to delineate, we're going to practice this, whether there is infiltrates in the posterior region of the right lower lobe, or are we talking more anterior? And there's not too much anterior except this particular portion right here. A good rule of thumb is if you have air in front of fluid, usually the air area, the lucency, becomes somewhat opacified. But if you have fluid in front of the air, you can't really appreciate the air because the fluid is always radio opaque. Here is the left lower lobe, same theory, same concepts. Most of the left lower is appreciated in the posterior plane on a lateral view, as you see here. So I'm going to jump back once again. Here's left lower lobe in an anterior plane, but most of it we know is located posteriorly. And the left lower lobe and the right lower lobe, if I'm jumping back here, these two, right lower and left lower, are predominantly what is responsible for a majority of our atelectasis in patients that are kept for many hours, days, maybe even weeks on their back in semi-Fowler's position, non-ambulatory. They begin to accumulate fluid. We get VQ mismatching and such. Here is the left upper lobe with the lingula. Now, the lingula, clinicians, anatomists alike will have differing opinions here, but that lingula is equivalent to the left middle lobe, even though we technically don't have a left middle lobe, as you know. But if they have a lingular infiltrate, atelectasis, whatever the case, pneumonia, this is the one that will silhouette with the left anterior cardiac border. And you lose your border, and you don't have an ability to clearly delineate where the heart stops potentially. We see this quite often. Here is the left upper with lingula, and this is the lingula all by itself. You can see if I have a lingular infiltrate where I have radiopacity, it is going to silhouette with the left anterior cardiac border. I'm going to lose the ability to appreciate its clear outline. And here is the left upper, last but not least, just by itself. Now look, I'll give you a little insight, especially you that are wanting to delve a little deeper into x-ray and you're afraid maybe you're going to say something in front of the radiologist or the pulmonologist that doesn't sound just right. It's never wrong to do a courtesy pause and to say, interesting. Because if you expected something to be there that wasn't, it's interesting. And if you find that something you thought was there is not, isn't that interesting? So courtesy pause with a little, that's interesting, will always get you in good graces most of the time. So let's look at a sample board exam question here. I know, why do we have board exam questions? Well, it's a chest x-ray. One, which of the following conditions results in an abnormal elevation of the left hemidiaphragm? Now we know the right is going to be elevated beyond the left because of the liver, but what would cause an elevation of the left? Take a moment. You absolutely know the answer. It's that left lower lobe atelectasis. Remember, anytime I have lung collapse, it's going to pull towards itself, P-U-L-L. If I collapse on someone, here's a good mnemonic device to help you remember. If I collapse on someone, I pull them down with me. Anytime you have lung collapse, it pulls towards itself. So if the atelectasis is severe enough, it will actually shift the mediastinum towards the affected side, whereas pressure pushes. So collapse pulls, pressure is going to push. Irrespective of whether you've been in bedside care for decades or just a few weeks, you can probably attest to this short list of the more common abnormalities. Now, this is certainly not an exhaustive list, but just a quick overview of the various considerations. For pneumothorax, increased lucencies with hypodensities noted in whichever affected lung field. For atelectasis, consolidation, and pneumonia, each present with relative opacity. In other words, more white, often have volume loss, an increase in opaqueness at the affected region. Everything essentially blends in to just whitish if you have atelectasis, consolidation, or pneumonia. For a pleural effusion, the trademark is a blunted costophrenic sulcus, also known as a blunted angle, sometimes called a meniscus sign. For any lesion or mass, a whitened region, sometimes linear, sometimes not, but always radiopaque. With air trapping or hyperinflation, it's similar to a pneumothorax, where you have increased lucencies, more black in the affected regions. But unlike with pneumothorax, with air trapping or hyperinflation, you don't have a definitive lung border or outline that is easily seen. I know it's a lot to take in, but we're going to put it into practice. So take a moment and let's use our systematic approach. We're going to practice it in real time for the first time here today. Start with your ABCDE. A is airway and adenopathy, B is bones, C is cardiac silhouette, D is diaphragm, and E is everything else. So the first thing I'm going to note here is I'm going to look at my airway. Is it midline? Well, I'm going to find my spinous processes, and I'm going to say it does look fairly midline, but there's a little bit of angle off towards maybe the patient's left as we get near to the carina. That's a little unusual. B for bones, this is where the abnormality comes in. So I'm looking at the spine, I'm looking at the ribs, and what I'll immediately note here, and feel free, throw it in the chat if you feel inclined, you'll notice there's a little offset to the spine itself. And unfortunately, with this patient, what you have here, if I can get it to come up, you got a fracture dislocation at T5 to T6. You can see the paraspinal hematoma as a bilateral posterior mediastinal shadow. That's what you're seeing here. This is not the aortic knob. You're silhouetting with that hematoma. Not that you have to know this. This is kind of a one-off, but I wanted to get the pump prime to start things out. So this one, I'll give you a little history here. It's off of a Medscape, a nice case study that shows you what is known as the sunburst sign. You've got ARDS, status post blunt chest trauma. This is the stuff you see all the time if you deal with motor vehicle accidents in the trauma bay. Bilateral air emphysema in the pectoral muscles. It's called the sunburst sign. You can actually see the muscle striations, and the air goes outside of the thorax. That's never normal. So you've got air that's actually transected in between the pec major and the pec minor muscle. Also, you've got what's known as the deep sulcus sign. That sulcus should not be that delineated all the way down into the pelvic region. We have free air here that's dissecting out the lung tissue from the diaphragm. They should always be in contact with a thin portion of fluid, but never separated as you see it here with the air. So take a moment just to kind of take it in. Obviously, it's labeled. Don't worry, they won't all be labeled. I'll give you a chance to practice. First thing I notice when I look at the airway is it's not perfectly midline. And when I say not perfectly midline, what we're saying is the spinous processes are our midline reference point. Well, here's the trachea, and you can see it's slightly offset towards the patient's left. Obviously, this is the right lung that's collapsed. You can see the outlining of the visceral pleura to the point where it's separated the right upper lobe from the right middle. That's pretty major. And that's the outlining of the lung tissue. All of this is free air. What you're noticing on this right side, you see no interstitial markings. You see no vascular markings. It's just ribs and lucencies. And compare it to the left side of the lung here. This is definitely a tension pneumothorax. And on top of that, we should never see the left hemidiaphragm elevated above the right. It should be opposite. So everything points to a pretty obvious pneumothorax here. All right, hopefully you're getting warmed up because these aren't labeled coming up. So start with your systematic approach. If you're systematic, you won't miss too much. Don't try to jump out there and find the abnormality. Some of these are more obvious than others. But just like on any diagnostic test, use a systematic approach. So let's do our ABCs. Airway looks to be midline, doesn't it? There's your spinous processes, the trachea perfectly aligned. B for bones, I'm looking for things like delineated ribs. Are there any dislocations, any displacements, any breaks, fractures, fissures? Don't see any. Are my clavicular heads aligned? Are my clavicles fractured, dislocated? Everything looks good. I don't see anything else for bones. My spine looks normal alignment. C, cardiac. I look like I don't really see a clearly delineated right anterior border. I do on the left side, so there's something maybe on the right. I look at D, diaphragm. It looks like my left and my right. Okay, my right's slightly elevated, which is to be expected, but it's flattened. And my left is smooth, rounded, and domed and parachute-shaped like a diaphragm should be. So there's some reason that this is flattened. E, everything else. Now I'm looking at vascular markings, interstitial markings. Oh, I lost them on this side. So this is, of course, the outlining of the lung. This is a tension pneumothorax on the right side. All of this is free air. You don't have any subcutaneous emphysema, but you've got air, free air in the thorax outside of the lung. This is the outlining of the visceral pleura of the lung tissue. Right lung, almost complete collapse. They're going to be difficult to ventilate. They're going to have an ET tube here shortly. So a little clinical history on this patient. This is a 46-year-old female that had a history of recurrent pleural effusions. And so without belaboring each one of these, because I've got to watch our time as well. We've got a little bit of time left, but quite a few to still go over. Just stay with your quick systematic approach. A for airway. I can see at the top it's not quite midline, but by the time I reach the actual thorax, it's fairly midline with maybe an arguably slight tortuous twist here towards the right-hand side, just ever so slightly. You can clearly delineate the carina and even see one of the main stem bronchi here on each side. You've got B, bones. I don't see any obvious breaks, fractures, fissures, dislocations. The spine looks like it's aligned. C, cardiac. I can see my right anterior border, my left, but you can really tell on the left-hand side it traces all the way to the diaphragm. Here I've got sort of a rounding that's happening, a blunting, and notice the volume on this right side is much less than the volume on the left. Don't ever hesitate to compare right to left, left to right. Your best reference point, especially on a first-time x-ray for a patient, would be their right side comparing it to their left and their left side comparing it to their right. I've got volume loss, sharp costophrenic sulcus here. There's my answer. I've got a blunted costophrenic sulcus. So this is a recurrent, this is a right pleural effusion. We have volume loss. Recall that if you have a significant amount of fluid in the pleural space, you're going to have adjacent lung compression. Are you going to have atelectasis? Sure. Now, are you able to differentiate between atelectasis and effusion? It's not always simple to do that. And much of the time in a radiology report, you will see they'll say, atelectasis versus effusion or cannot clearly delineate. Some are more confident than others, but I would argue unless you know Hounsfield units and you're actually scanning the different densities with the naked eye, it's almost impossible to tell the difference between a significant lung collapse and an effusion. Here's the only way you can tell the difference. And if you've been sleeping up until this point, you can take this one the rest of your career. If you've got volume loss and it's from atelectasis, remember atelectasis pulls towards itself. You're going to have a shifting of the mediastinum, maybe even tracheal deviation. With a pleural effusion, that collapse of lung tissue is filled with fluid, so you don't have the ability to create sort of that vacuum where it pulls towards itself. So with an effusion, there will be atelectasis present, but the underlying primary, if it's effusion, you won't have as much shifting towards the affected side versus atelectasis where you have shifting towards the affected side. Now, this is that same patient, the middle-aged female that had the recurrent pleural effusions, but this is from a left lateral view, so it's from the patient's point of view. When we say left lateral, it is from the side on the patient's left side. This is the spine, and this would be the thorax itself, the front of the thorax. And you can see the difference in the hemidiaphragm. Now, it's near impossible, just at first glance, to tell the difference between a right hemidiaphragm and a left if you don't have a frontal to compare it to. We can make the assumption that the right is elevated above the left, and that's a true statement. But you have, case in point here, you have a severe elevation of the right versus the left, and in one we looked at prior, it was reversed. So I do assume, because I had the frontal view, that that has to be the right, and it happens to be the one that's more flat. I can see a clearly delineated sulcus here, and I kind of lose it in this general area. This is where all the fluid is located. Can you tell? I may have to darken the lights in the room there, but can you tell there is a greater density here? There's more radio opacity in this area, and that's where the effusion is located. Just takes a little practice. So starting again back with your original technique, take your time. I'm going to stop talking for just a moment. See if you can interpret this x-ray using ABCDE method. Airway and adenopathy, bones, C for cardiac, D diaphragm, E everything else. I'll give you one moment. Stay with your system. The first thing you're going to see is the airway itself is offset. And it's offset towards which direction? The patient's right. So my airway is patent. I do not have an artificial airway. We'll look at some example of an artificial coming up. So the patient is spontaneously breathing. They could be on non-invasive. I can't see their face, but they're not intubated. They don't have a tracheostomy, tube at least. Could they have a stoma? It's possible, but it's not midline. Here is your midline, your spinous processes of your vertebral bodies. So we're way off. We're way rotated towards the right. Your clavicles, although the clavicular heads are aligned, notice the acromial end of the clavicles. My left is much more elevated than my right. So this patient is malpositioned in the bed. That's my bones part. We already established airway is offset towards the right. I don't see any obvious breaks, fractures, fissures, but I do notice I've got a significant amount. If I look at diaphragm, I've got diaphragm here, no diaphragm. E, everything else. Cardiac, I've got this side, not this side. I've got complete whiteout on most of that right lung. Could it be a pleural effusion? It's very possible, but more than a pleural effusion, which fills the space with fluid instead of air, most likely I have a massive atelectasis, an almost complete right lung collapse. Now, without getting too deep into how to fix the issue, some of you are already thinking about some of your bronchial hygiene, your hyperinflation therapies. Do they need mechanical ventilation? We'd certainly want to put the patient right side up, bad lung up, to try to force gas, the path of least resistance. But you've got significant volume loss of that right side. On occasion, you don't see it here, but on occasion on the unaffected side, you will see compensatory hyperinflation, where gas, because it follows the path of least resistance, it flows through, it meets resistance, and all of the gas is redirected to what we would consider the good lung. Now, one more thing in passing before we move forward. In this patient, you do not have compensatory hyperinflation necessarily according to lucency, but you do have an increase in vascular markings and interstitial markings. This patient is a fluid overload nightmare with atelectasis atop everything else. I suspect they're going to need thoracentesis. They may need mechanical ventilation, but they're going to need diuretics and some other things. But we're not really talking as much about treatment today, although it is tempting. So what do you see here? Well, there's a lot more to see and do. It's like going from Six Flags to Disneyland. Now there's a lot more. So you've got the airway that is difficult to delineate, although I do now have an artificial airway. So we've got this radio-opaque line, and you that commonly look at the ET tube, yes, we need to know it's in good position. The depth of insertion is adequate. Usually depth of insertion just a couple of centimeters or so above the carina. Not so much in the neo-peds population. Hey, a couple of centimeters would have you extubated, right? I almost said excommunicated, but if you did extubate a neo, you might get excommunicated from RT for that day. But let's look at our film here. Take a moment, go through, use a systematic approach on your own here for a few moments. So it looks like my ET tube is here. The airway appears to be somewhat midline. I do have a little bit of curvature of the spine. I don't see any obvious breaks or fractures or severances or complete changes in direction. The patient could be malpositioned in the bed, maybe a little scoliosis. I don't know their history and completion here. As far as bones, they're not easily seen, but I don't see any obvious fractures, breaks, fissures. Ribs look good. Cardiac, I can see my right anterior border, but I can't so much see my left. It is silhouetted with all of these infiltrates. I mean, there's infiltrates bilaterally. This is what we call fluffy or puffy infiltrates bilaterally, but we're not done with the ABCs. We've got the D, diaphragm. I can see it's fairly delineated, but not with clarity on both sides. The right is slightly elevated above the left. The sulcus, I believe we're getting a little artifact from this anterior rib coming across. That one looks sharp. I don't suspect any effusions present, at least enough to manifest the meniscus sign. E, everything else, we definitely have some catheters and such. Looks to be we have just your typical ECG, electrode leads here. It looks like we've got, yes, the ET tube. If I look closely, probably an NG or OG. I can't see if it's nasal or a gastric, and it looks like it goes into the antrum of the stomach. This is probably just some catheter laying across as well. Nothing else really penetrating the body. I don't see a central line, a PICC line, or portocath or anything. So this technically is probably ARDS, acute respiratory distress syndrome, but could also be similar to COVID-19. Oh my God, we said the C word, my apologies. COVID-19, it could be, or any type of severe pulmonary edema. It's also known as an alveolar pattern, or what is considered non-vascular haziness. How do you consider something vascular versus non? The key is, do you see prominent vascular markings branching from the great vessels, the hilar region, to the periphery? If you cannot trace it from the parahilar region to the periphery, it is less vascular and more alveolar, and that's what you're seeing here. This is definitely an ARDS-like state. So this is labeled just because I feel like you're going to see it eventually, if you have not already, multiple times. I know that this isn't a presentation on cardiovascular care, but a implantable cardioverter defibrillator has a completely different purpose than the typical pacemaker, in that an ICD, that implantable cardioverter defibrillator, is purposed to deliver a shock similar to a common external defibrillator, and therefore it's going to employ thicker shock coils, as you can see here in the lower right of the photo. There's a lot more power and voltage than a standard pacer. Pacer is about 15 microjoules. When you're talking about an ICD, we're talking 20 to 40 joules. That's a lot more. So here we have several things. So if I start with my airway, it looks to be midline. I mean, it doesn't have to be perfect. It's not significantly offset. You could argue slightly towards the right, but I feel that may be positional. Now, we've cut off the costophonic sulcus on the right side, and you'll get that occasionally where the film is not adequate, and sometimes an ordering provider will say, well, we need to reshoot it, or they'll just make a decision based on what they have. But staying with our system of ABCDE, A for airway and adenopathy, B for bone, C for cardiac, D diaphragm, and E everything else, my airway fairly midline, slightly offset towards the right. Here's my adult carina, and I don't see any adenopathy here. I do see some vascular markings and what probably is a little bit of what's known as bronchial cuffing here. That's when you've got edematous bronchi that sort of show up like a little donut. You've got cardiac. Right anterior border is seemingly silhouetting with the spine, which happens on occasion. And on the left-hand side, it's fairly delineated until we get near the midlung. Now, could it be breast tissue? Well, I don't have it on the right, and I don't know this patient's history. I'm going to make the assumption we could have an infiltrate, maybe even a little loculated effusion here. The reason I don't think it's fluid, and I think it may be something more like what we say is plate atelectasis, more of a linear collapse, is because this does not have a fluid density. Fluid density, the easiest way to compare it on a patient is what does their heart look like, because it is filled with fluid, it's filled with blood. And here we still have some pretty decent aeration. So that's probably more of a linear plate-like atelectasis, sort of a collapse in a general area. D for diaphragm, right is elevated above the left. They both have kind of a dome shape to them. I do not see the sulcus, but I assume it's not blunted beyond this point. And on the left side, I can see it's quite sharp. So once again, we've got just a typical X-ray where you have multiple different densities, a lot of which are not necessarily vascular, but just what we call prominent interstitial markings. You see this a lot with fluid overloaded patients. Obviously, this patient's got a history of cardiovascular disease if they have an ICD with a implantable shock lead there. So this is not something you see every day. I'll give you a little bit of history on this patient just to give you a little break, and we'll go back to our system. It's called vanishing lung syndrome. Vanishing lung syndrome is a distinct clinical syndrome describing these giant bullous emphysematous changes. And radiographic criteria for this so-called vanishing lung has been around since the late 80s, which, by the way, what a great decade, those 80s, right? That music that was playing got us pumped up before we got on. And it describes giant bullae in one or both upper lobes occupying at least a third of the hemithorax. And of course, it compresses the surrounding parenchyma. Traditional risk factors are always going to be the same: tobacco smoking, marijuana use, or good old-fashioned alpha-1 antitrypsin deficiency. This is a younger person, by the way. And vanishing lung typically occurs in young, thin male smokers, and it's very progressive. It's unknown typical etiologies beyond maybe a genetic predisposition. The comparison of the chest X-ray with what I'll show you here, the high-resolution CT scan from just 4 months previous, revealed the bullseye in this young man, and fortunately to have progressed in size, which confirmed the diagnosis. And I've seen this a few times in clinical practice where you get this, they call it idiopathic giant bullae emphysema. And it's a very rare manifestation of COPD seen in younger marijuana users or even middle-aged tobacco smokers with alpha-1. Here's the CT of that same patient. You can see there's no lung tissue here at all. This is just air. The only lung that we're really ventilating is here. Pretty despicable quality of life, very difficult to do any type of exercise or even certain activities of daily living. You won't see this every day, but it does occasionally come across. This is the same patient. as the prior two slides. Keep in mind, this is a young person in their, if I recall, early 20s. So it's unfortunate, but it's not a pneumothorax. This is bulle disease. How do I know, or how do I differentiate it from a pneumothorax? Well, a pneumothorax, I'll back up, let you see it here. A pneumothorax is not going to allow this perfect encapsulation of air unless you have significant adhesions, but even an adhesion is not going to keep air from escaping around that scar tissue into the different cavitary regions of the thorax. So it's just too linear here, and I don't see a compressed lung. What I am seeing is infolding. So all of this here, these darker lines, these are not ribs. This is infolding of lung tissue, where you have overlapping of tissue that happens in layers and creates an increase in radio opacity or an increase in density. Those are just little things to pick up on. It takes practice, but if you're systematic, you won't miss a whole lot. So got a few more for you here. Hopefully you're not getting too fatigued visually. I know we're looking at a lot of black and white, but I wanted to definitely give you some examples, some of the more common stuff you'll see. So stay with your system. ABCDE, airway adenopathy, B bones, C cardiac, D diaphragm, E everything else. Fairly midline is the airway, maybe slightly offset towards the right, ever so slightly, so do keep that in mind. I don't see adenopathy, although there are some prominent lymph nodes here. You might get a radiologist or two that may say they have mild lymphadenopathy. B bones, there's no breaks, fractures, fissures. You would typically know if you're suspecting there to be some type of bone abnormality, but stranger things have happened. For C cardiac, I can see my left anterior border quite well. My right is completely gone. So what does this tell you? If I was in a room full of people, I would love somebody to shout it out to me, but I'll watch the chat as well. This tells me that I most likely have a right middle lobe infiltrate. And in this case, it's just good old-fashioned pneumonia. The pneumonia, which nobody wants to have a patient that develops pneumonia while in the hospital, but it does happen. It could be from aspiration or just from a pre-existing infection, or, certainly not RT, of course, but maybe it was introduced by another healthcare provider. RTs, we only make mistakes on Mondays and only once a month, right? So when it comes to pneumonia, it can be described as just an infiltrate, or they may actually put suspicion pneumonia. You know immediately what's happening here if you're kind of practicing as we go along. I do like to use this chest x-ray, though, for now as a very clear delineation of the T1, very prominent and the widest transverse process of all vertebral bodies of the thorax. So that lets me know I'm at T1. And you say, what's the concern that we know where T1 lies? Well, if you're one of those clinicians that are documenting the depth of insertion of the ET tube at a certain thoracic vertebrae, this is very helpful. So the widest transverse process, there's T1, 2, 3, 4, and as we mentioned, right around T4, T5 every time. There's where the adult carina can be found. So the airway is slightly offset towards the right. You can see the patient's neck is bent here. There's not lymphadenopathy, but there's a prominent hilar region. The vascular markings are quite prominent. The pulmonary artery and pulmonary veins are quite prominent. B bones, I don't really see a whole lot, but I do see what appears to be a metallic density, just kind of random artifact. It could be staples. It could be old clips. They could have had some kind of procedure done on that left side. Just give me something to keep you awake there. The cardiac, I can see right anterior border clearly delineated in the left, but notice it's very obvious the left anterior cardiac border is more traceable down to the diaphragm than it would be here. So I definitely have volume loss on this side, and I have a little bit of compensatory hyperinflation. And you say, well, there's not significant hyperinflation because it's not hyperlucent, but what I have is an increase in rib spacing. Look at this side versus this side, much wider. These are discrete findings, but if you train yourself to be detail-oriented and you're meticulous, you won't miss a whole lot. And sometimes I think you can agree on the call that we're one of the first people that have the ability to pull up the chest x-ray. We're at bedside setting up mechanical ventilation, maybe intubation, and they're shooting the x-ray right after some kind of intervention. So you may be first on the scene to arrive and figure out what's really going on. So there's a pretty large pleural effusion here. Got volume loss, a little compensatory hyperinflation of the unaffected side. And we've got some pretty significant gastric bubbles here. I had a professor call them a UBF, an unborn fart, but we can't say that on the call. Oh, I just said it, didn't I? So here we've got Another patient, if you start with your systematic approach, the airway's midline, I don't see any obvious fractures, breaks, fissures of the bone, dislocations. One thing I do notice, and I'll come back to, is when we get to cardiac, I can see my right anterior border. I can see my left anterior, but there's something a little unusual right in here. Now, there is a rib that's causing a bit of artifact, but if you look closely, I don't really have an ability to trace it all the way down the diaphragm. So there's a little infiltrate in this left lower lobe region. Maybe even the lingula could be involved in the left lobe here. One thing I want to note, though, that's really prominent in this patient, you see the aorta, the descending aorta here, how it's really more of a darker density. This person has what would be considered aortic ectasia. You'll see that sometimes denoted on that chest x-ray report. Ectasia just means a widening of a tube. Anytime you have aortic ectasia, it could imply that they're developing maybe an aneurysm, or they have chronic hypertension, under-controlled or not well-controlled, or maybe they're developing a hypertensive crisis. I would look for things like an uncoiling of the aorta, prominent aortic knob. Don't really have that here, but I would argue there's some calcium here. Calcification ring is beginning. A good way to tell if their aorta is widened is the border of the right and left wider than the spine itself. That's a good indication. But what we have here, if you look close, everything else, I kind of baited you for this one. So A is airway, B is bone, C cardiac, D diaphragm, E is everything else. We have a little lesion here, don't we? A little mass, a little nodule. It is a granuloma. Now, it's not really calcium density, which would be metallic in the darkest density. It's more of a soft tissue density. It does have an irregular border. Would it be sampled or biopsied? It's possible. I don't see any spiculations, any root-like projections. It's not calcified, but it's a little granuloma in that right lower lobe. Again, we're not necessarily talking about treatment today. In this case, one of the first things you'll note, just to redeem a little time here, because we will run out, is I have sternotomy wires. So the patient has probably had some type of maybe open heart surgery or a procedure, at least where they did a thoracotomy. But there is a right hilar lung mass with a little bit of lymphadenopathy here. That is a large mass that you do not normally see on a chest x-ray, much less you don't see it on their left side. So that tells me for this patient, it's a pretty significant abnormality. The patient could have had a CABG, again, with the sternotomy wires, but they've had a thoracotomy nonetheless. So you know there is some degree, most likely, of cardiovascular disease, or they've had some type of a pathology requiring us to open the chest. This is a good example of what's known as air trapping or hyperinflation. Note the rib spaces here, even compared to the left lung on this side, is much more widened. Here's that bronchial cuffing again. I mentioned that earlier, where you have a bronchi that just happens to hit the film just right. Looks kind of like a little donut. It should not be thickened like that unless there's some edema present. So here's a lateral film of the same patient at the same time as the frontal view chest x-ray. And note the hyperlucent or the dark black and that really prominent retrosternal airspace. I mean, this is barrel chest if I've ever seen it. Here's that retrosternal airspace, and look how beautiful the aorta is shown here. You don't see that very often. But sometimes when you get a really well-penetrated x-ray with very little muscle tissue, almost no adipose tissue, you get some really beautiful views that you're seeing here. And on a really well-shot chest x-ray, you may even be able to start picking up on some calcified coronary perfusion. So this patient's got some pretty significant cardiovascular disease, coronary artery disease, if I can be so bold. And you've got flattened diaphragms, but that retrosternal airspace and what we call hyperlucency is there in full effect. Something you may not see every day unless you work in a particular clinic or practice. Do recall that with chest x-rays, of course, description can help with diagnosis. Think about things, what you're seeing here, such as shadows, opacities, or densities. What's the size of the nodules? Are they on both sides? That could maybe imply there's some dissemination. Are there multiple nodules? Is it widespread? Is it mainly in the middle of the lower zones, or is it upper lung? What's the shape? Are the borders irregular? Are they linear? Is there a nodular pattern? Is there a soft tissue density? Are they calcified? Unfortunately, this is an example of metastatic disease. It's got a very distinct, diffuse nodular pattern. So this is what lung cancer looks like in some ways. And you've got a little calcification ring there. There's some cardiovascular disease atop everything else, fortunately. Okay, we're almost there. So this is a very unusual case to end things off today, and we'll take some questions. A very unusual case of what's known as primary spontaneous hemopneumothorax in a young man with atypical tension pneumothorax. It's a case report, so you don't see it every day. And look, I hope you never see it. It's very odd. It's a really discrete marking here that lets us know there's a pneumothorax. So that is not the scapular shadow. I can't stress it enough in closing here that you need to compare the patient's right to their left. If you would have thought that was a scapular shadow, there's not one on the left side. So that tells me that's the outlining of the lung. That is the visceral pleura. And you can see the interstitial and vascular markings are very prominent to the periphery of the lung, but it ends distinctly right here in a linear pattern. So everything to the right of my mouse, to the patient's right, I should say, my mouse is all free air. And you've got a really prominent pulmonary artery to the point, I would argue, there's something very unusual here that you don't see every day, probably has a little bit of mucosal edema as well. So in closing, remember, not everything is always black and white. I mean, I know on X-ray it kind of is, but there's always a little gray area. And any questions you have, feel free to put it on the chat. I think Mr. Barnes is going to turn your mics on.